Okay, good evening, everyone. So my name is Maxime Cannesson. Thank you, Michael, for the nice introduction. And tonight I'm going to talk to you about non-invasive and continuous monitoring of what we call the Pleth Variability Index, or the PVI. And what I will try to show you is that actually today in the operating room, when we take care of patients, and especially moderate to high-risk patients, we probably need more information about the flow and about oxygen delivery. And today we have some non-invasive tool that may be helpful for optimization of fluid and of the hemodynamic of our patient. So as you know, every year around the world we have about 240 million anesthetic procedures that are performed. Among these 240 million, high-risk surgery represents 10% of them, so it's about 24 million. But you have to remember that these 10%, they account for approximately 80% of the mortality during anesthesia. When we look at moderate risk surgery, this moderate risk surgery, they represent 40% of the 240 million patients, so it's 96 million patients. And among them, about 40% are going to present a minor complication, most of the time related to the guts, like postoperative nausea and vomiting. And this minor complication increased dramatically the cost of the surgery. And in all of these patients, high-risk patients or moderate-risk patients, what has been shown is that most of these complications are actually related to an inadequate resuscitation and to tissue hypoperfusion. If we go back to the basic physiology, here you see Arthur Guyton and his wife here. What we learn is that the goal of the circulation is to provide the tissue with oxygen and nutrients. And if we want to achieve this goal, then we need two objectives. The first one is an adequate perfusion pressure to force the blood into the capillaries of the organs. And that we monitor arterial pressure every day in the operating room. But what we also learn is that we need a flow to deliver the oxygen to the tissue. And basically, the oxygen delivery equation that you can see here involved the hemoglobin, the SaO2, and the cardiac output. It also involves the PaO2, but this is neglectable because it's a very low value for the oxygen delivery. So what we'll try to see is that we can obviously monitor the SaO2 non-invasively. I think that we'll discuss the potential ability to monitor hemoglobin non-invasively. And when it comes to cardiac output, we'll see how we can use non-invasive cardiac output monitor or more likely use surrogates for the assessment of cardiac output and cardiac output optimization. And finally, when we look at the clinics and we look at cardiac output optimization in the clinical world, today we have more than 15 or 20 studies, independent studies, randomized studies, showing that cardiac output optimization or maximization has the ability to improve our patient's outcome, to decrease the cost of surgery. How does it work? To understand this concept of cardiac output maximization, we have to go back to the Frank-Starling relationship. The Frank-Starling relationship is the relationship between the preload of the ventricle that you can see here on the x-axis and the stroke volume on the y-axis. And this relationship, the Frank-Starling, has two portions, a steep portion here, followed by a plateau. What is cardiac output maximization? You monitor cardiac output and you give fluid in order to maximize it. And when the patient is on the steep portion, increasing the cardiac output by giving fluid to the patient will bring the patient on this part of the relationship. And when we reach the plateau, increasing the preload is going to induce a small increase in stroke volume, and then you know that you've reached the plateau and you've maximized cardiac output. And this is the concept of cardiac output maximization. And this approach, using especially devices like the esophageal Doppler, has been shown to improve patients' outcome. The problem is that, once again, if we monitor arterial pressure every day, cardiac output is not monitored on a daily basis, even in high-risk surgery patients. And when we monitor it, most of the time we use very highly invasive devices. When it comes to the concept of volume expansion and trying to predict the effect of volume expansion on cardiac output, we also use most of the time what we call static parameters, like the central venous pressure or the wedge pressure. And what we've learned recently and during the past 10 or 15 years is that finally this parameter, the CVP or the wedge pressure, are very poor predictors of fluid responsiveness meaning that they do not predict the effect of a volume expansion on cardiac output. And in a recent meta-analysis published by Paul Maric, he clearly states that CVP should not be used to make clinical decisions regarding fluid management in these patients. CVP is not accurate to predict fluid responsiveness, and it's a very invasive monitor, as you know. More recently, authors have started to focus on what we call the dynamic parameters of fluid responsiveness based on cardiopulmonary interactions, and most of the time we use the parameters like the pulse pressure variation, where we can assess the respiratory variation in the arterial pulse pressure. This has been described in 2000 by Frédéric Michard and Jean-Louis Teboul. And actually, when you look at an arterial pressure like this, in some patients, you observe very important respiratory variation. You can quantify this respiratory variation. And when these respiratory variations are very high, it is more likely that the patient is on the steep portion of the Frank-Starling curve. That in this case, the patient is a fluid responder, and you can today quantify this parameter and conduct goal-directed therapy using it. I will show you how to do that. The only problem with this parameter is that they are invasive. You need an arterial line to do it, and not all of our patients are equipped with such a device. So to summarize, when you look at the arterial pressure waveform, if you have big respiratory variation like this, here you have an arterial pressure waveform with big respiratory variation. The pulse pressure variation is said to be 24%. It means that the patient is on the steep portion of the Frank-Starling relationship. The patient is going to be a fluid responder. And then if the respiratory variation are small, like here, 10%, you know that the patient is on the plateau. It means that looking at the respiratory variation in the arterial pressure, you can evaluate whether the cardiac output is optimized or not, meaning you can evaluate whether the cardiac output of the patient is on the steep portion or on the plateau. But once again, the problem is that the arterial pressure is invasive, and we don't use it for all of our patients. So what about the pulse oximeter waveform? You know the pulse oximeter waveform, we are using this device every day in the operating room. It's non-invasive, it's universal, and it's almost mandatory for performing anesthesia today all around the world. So the pulse oximeter waveform relies on light absorption through the finger, the ear, on the forehead. Basically, it has two components, this light absorption. One part of the absorption is a constant absorption. It's related to the skin, to the nail, to the bone, or to any tissue at the site of measurement. And the other part is a pulsatile component of the light absorption that is related to arterialized blood. And finally, when you look at the pulse oximeter waveform, you have a waveform that looks a little bit like an arterial pressure waveform. It's not exactly the same, but it's related to the arterial pulse and the light absorption at the site of measurement. And it is possible to measure and to monitor the respiratory variation in the pulse oximeter waveform. And today we also have more than 20 or 25 papers showing that the respiratory variation in the plethysmographic waveform are related to the respiratory variations in the arterial pressure waveform. The only difference, of course, is that the plethysmographic waveform is obtained non-invasively. So here is a plethysmographic waveform. It's a SpO2 waveform that you can observe. You observe clear respiratory variation in this waveform. You have here, for example, a single respiratory cycle. And you can see that you have a maximum amplitude of the waveform here, and 3 bits later, you have a minimum amplitude. And you can calculate and then compute the respiratory variation in the plethysmographic waveform. And we called, when we describe this index, the delta pop, the respiratory variation in the amplitude of the pulse oximeter waveform. This is a figure showing an arterial pressure waveform and a plethysmographic waveform. And you can see that both waveforms are almost superimposable. You see the waveform at the top here, present, for example here, a maximum amplitude, and 2 bits later, a minimum amplitude. And when you look at the waveform below, you can see that the respiratory variations are exactly the same, and you find the maximum and minimum amplitude at the exact same bit between the arterial pressure and between the plethysmographic waveform. So the waveform here above is the arterial pressure, and the one here below is the pulse oximeter waveform. And finally, in a study that has been published more recently, we tested the ability of this parameter to predict fluid responsiveness in patients under mechanical ventilation and general anesthesia. And we found that patients who had a big respiratory variation in the plethysmographic waveform were more likely to be responder to fluid response to volume expansion. These patients were on the steep portion of the Frank-Starling relationship, while when we have no respiratory variation here, it's more likely that if you give fluid to this patient, cardiac output is not going to increase because they are on the plateau of the Frank-Starling relationship. So these parameters are non-invasive and are able to predict fluid responsiveness in mechanically ventilated patients under general anesthesia. And more recently, in 2010, a group from Israel, from Dr. Pizov, showed that when you induce hypovolemia in a patient, you draw blood, they induce hemorrhage, and they draw up to 20% of the estimated blood volume of the patient. They observed that in this patient, the mean arterial pressure does not change. They selected only patients who did not change the mean arterial pressure, meaning the very challenging patient where hypovolemia is installed, and you cannot detect it on a decrease in mean arterial pressure. But when you look at the respiratory variation in the plethysmographic waveform, very quickly, you observe an increase in the delta pop and in other parameters derived from the plethysmographic waveform. It means these patients have no decrease in mean arterial pressure, they bleed, and the plethysmographic waveform, the respiratory variation, increase very quickly. So these parameters are also early detectors of hypovolemia. You have to keep in mind that all of these parameters, they have limitations. They can only be used in mechanically ventilated patients, patients under general anesthesia with a tidal volume more than 8 milliliters per kilogram of body weight, no arrhythmia, no right ventricular dysfunction, and also for the plethysmographic waveform, the vasomotor tone may have an impact when the quality of the waveform is too small, when the perfusion index is too small. It may be a problem for evaluating the respiratory variation in this patient. So all these concepts surrounding the respiratory variation of the plethysmographic waveform, the problem is that when we did this study, or other group performed this study, they used sophisticated software to download the plethysmographic waveform, analyze it. So these parameters were not easily available in the operating room, and you cannot eyeball them because most of the time the plethysmographic waveform are processed and smooth, and you lose the information. And so there was a need for automatic monitoring of this parameter, and that's when Massimo came with the Pleth Variability Index. That is a software allowing for the automatic and continuous monitoring of this respiratory variation in the SpO2 waveform. Once again, if you go back to the plethysmographic waveform itself, you have a pulsatile component, that is the AC, we call it, and the continuous absorption, that we call the DC. The perfusion index is the ratio between AC and DC. It's a percentage. Most of the time, the value is around 4 or 5%. And so it reflects the amplitude of the waveform that we have on the pulse oximeter. And the PVI is going to calculate the respiratory variations in this perfusion index, meaning that it's going to calculate the respiratory variation in the amplitude of the waveform. So we conducted some studies on this parameter, and other groups did the same. This was the first study we did. We studied patients in the operating room, mechanically ventilated patients. We performed volume expansion. We monitor cardiac output before and after volume expansion. And what we observed, for example, in this first patient, this patient was a responder to volume expansion. The plethysmographic waveform showed big respiratory variation, and the PVI, meaning the value that you have on your device that is automatically calculated, was 30%. And then over this 15-minute period of time, we gave a bolus of 500 milliliters of colloid, and you observe a decrease in the Pleth Variability Index that reached, at the end of the volume expansion, a value around 10. So it means that when we give fluid to the patient, the respiratory variation decreases because the patient goes from the steep portion to the plateau of the Frank-Starling relationship. This patient was a non-responder. Before volume expansion, the patient had no respiratory variation, as you can see here visually. The PVI was 10, so the PVI calculated this respiratory variation and found that they were low. You give fluid, and the PVI does not change. It has a little trend to decrease a little bit, and this patient was non-responder, meaning that when the PVI is high, and we found that when it's above 14 or 15%, it's more likely that the patient is going to be responder to volume expansion. When it's less than 14%, it's more likely that the patient is going to be a non-responder volume expansion, and we came up with an expression saying high is dry. When these parameters are high, it's more likely that the patient is dry, and then if we give fluid, cardiac output is going to increase. This ability to predict fluid responsiveness in this study was assessed using what we call ROC curve. The biggest the area under these curves, the best is the predictive value of the index. You can see that the CVP is here in blue. The area under the curve is very small, and for dynamic parameter derived from the plethysmographic waveform, like the PVI or the pulse pressure variation, the area under the curves were much bigger, meaning that this parameter were better predictor of fluid responsiveness than the central venous pressure or even the wedge pressure. Other groups focused on this parameter and did the same kind of study. Here, a study finding the exact same results in anesthesia, a study coming from Germany, where PVI was a predictor of fluid responsiveness, like stroke volume variation, the same result, exactly the same sensitivity and specificity. This study is in press. It comes from France, and it's a study that has been performed in the ICU, intensive care units, where they found that PVI was able to predict fluid responsiveness in patients in the intensive care unit. These patients, most of the time, have a bad quality of the waveform, but still this group was able to find a very good predictive value for PVI. And this predictive value, as you can see here again, was much better than the central venous pressure in this ICU patient. Meaning that when you use this technology, when you want to know whether fluid is going to have an impact on cardiac output or not, these parameters do better than the central venous pressure that is invasive and unreliable. So now we know that we are able to predict the effect of fluid on cardiac output. And then let's go back to the beginning of the presentation where we talk about cardiac output maximization that has been shown to improve patient's outcome. You know, when you look at the pulse pressure variation or the PVI, you know whether you'll be able to increase cardiac output or not. And then it can drive the fluid that you are going to give to the patient, and it can change your decision-making process. I remind you this concept of cardiac output maximization. You give fluid to the patient. You need to monitor cardiac output. You give fluid until cardiac output does not increase anymore after a fluid administration, and then you know that you have reached the plateau of the Frank-Starling relationship. This is the concept of cardiac output maximization. This has been shown to improve patient's outcome, to decrease the cost of the surgery. Well, this concept of cardiac output maximization could be achieved using a concept like the pulse pressure variation or PVI minimization. It means that when you have a big respiratory variation in the arterial pressure or in the PVI like this, you know that you are on the steep portion of the Frank-Starling relationship. You can give fluid to the patient until you observe no more respiratory variation, and then you can assume that you've reached the plateau. And applying this concept, instead of conducting cardiac output maximization, we could conduct PPV or dynamic parameter or PVI minimization and try to keep the patient with low respiratory variation in the plethysmographic waveform or in the arterial pressure waveform. This approach has been already tested in studies. The first study that tested it was on pulse pressure variation. It was published a few years ago, 3 years ago. There are two groups, one group with a normal fluid administration based on a normal parameter like central venous pressure and so on, and another group where patients were monitored for the pulse pressure variation, and the physician gave fluid to the patient in order to give a pulse pressure variation less than 10%. And what they found at the end of this study was that this patient, the mechanical ventilation was less long in the intervention group. The ICU stay was shorter, and the hospital stay was shorter in the patient who were optimized for pulse pressure variation, because it's probably the same concept than the concept of cardiac output optimization. You optimize the pulse pressure variation, you decrease it, and then you know that you have optimized your cardiac output. For the Pleth Variability Index, a recent studies from Belgium has tested the ability of goal-directed therapy based on PVI to change patients' outcome. The same idea, you have a group where fluid administration is based on the clinician experience, on clinical value. And in the other group, the physician monitored the PVI and gave fluid in order to keep the PVI below 10%, under 10%. And in this study, they included 97 patients, 11 were excluded, so at the end they had 86 patients. One One half of the patients, so 41 patients, went into the treatment group. That was the control group where fluid administration was based on clinician experience. And the other one was the protocol group where the fluid was given based on the PVI. And once again, in order to keep PVI low, then you know that the patient is on the plateau of the Frank-Starling relationship. And at the end of this study, the author showed that first, this was feasible. It's feasible to use this non-invasive parameter and to perform goal-directed therapy. You can use this parameter that is derived from the pulse oximeter waveform and titrate your fluid administration based on this parameter. And what they found is that after the surgery, the group was monitored with PVI and optimized with PVI at a significantly lower lactate level than the control group. And you know that the lactate level after the surgery have been linked closely to the postoperative complication, or at least it shows that the oxygenation of the tissue has been better in the protocol group than in the control group. So it was 82 patients. They reduced the postoperative lactate level, and they also found that they decreased the quantity of fluid that was administered to the patient when they monitor the Pleth variability index. So as a conclusion, I think that you can see that PVI can predict fluid responsiveness in patients under general anesthesia. And once again, the fluid responsiveness is the ability of volume expansion to increase cardiac output. So PVI can predict the effect of volume expansion on cardiac output. And it has potential clinical application for oxygen delivery and fluid management optimization in our patient. And when you go back to oxygen delivery and the equation that we've seen at the beginning, the idea of this parameter is that they are totally non-invasive and widely available. You know that SCO2 can be obtained non-invasively using the SpO2. Hemoglobin has potential to be monitored non-invasively, as we'll see probably with Dr. Miller. And this concept of cardiac output maximization can be obtained with this concept of minimization of the PVI. And so in the oxygen delivery equation, we could use the inverse of PVI to assess the cardiac output optimization and maybe being able to monitor and optimize oxygen delivery totally non-invasively in our patient and hopefully improve our patient's outcome. Thank you very much.